All right, thank you so much for that update. We're going to move right into our Q&A with the state panel. I'm going to call up our state lab panelists, and we also have Dr. Malik and Dr. DeBarba who can answer questions as well during this time. If I mispronounce any names, I apologize. So online joining us is Tracey Bishop from California. And then in person, please come up, Angela Wittenauer from Georgia. We have Khaja Basheeruddin from Illinois joining us online. Barb Lesko from Indiana. Zach Leeker and Darrin Sevier from Kansas. Sondra Rosendahl is joining us from Minnesota online. Miriam Schachter from New Jersey. Joe Orsini from New York. Jamie Mills from North Carolina. Margie Ream from Ohio. Taraka Donti from Pennsylvania. Gwendolyn McKee from Tennessee. Nicolas Szabo from Utah. And Mai Baker from Wisconsin. So please come on up, and this is going to be just a discussion Q&A. I'm going to turn over the moderating responsibilities to Dr. Matern to lead the Q&A, and I'm going to make sure we have enough chairs. Good.
All right. Thank you guys for being willing to be part of this panel where we want to discuss what's going on with newborn screening for Krabbe disease in the various states. There are a bunch of questions that probably you cannot read because they're behind you. Should we quickly do so that everyone knows which state is represented by who? Joe, why don't you start? You should be fast.
You have Joe Orsini from the state of New York.
Darrin Sevier from Kentucky.
May Baker from Wisconsin.
Gwendolyn McKee, Tennessee.
Jamie Mills from North Carolina.
Barb Lesko, Indiana.
Donti from Pennsylvania.
Margie, Ream, Ohio. I'm not employed by the lab, but chair the advisory committee.
Miriam Schachter from New Jersey.
Leeker from Kansas.
Eric Malak from Maryland.
Angela Wittenauer from Georgia.
Nicolas Szabo from Utah.
Okay, thank you very much. So let's start off. I'm going to read the first question here. If someone has a magnifying glass, then bring it by. So Krabbe disease is a time-critical condition. However, it is more important to get a baby with infantile Krabbe disease to a transplant within 30 days of life than it is to report preliminary results on the 5th day of life. Has this been considered by your program advisory committee? So why is this question there? Because on the RUSP, there are time-critical conditions. Again, if you look at the RUSP on the website that is still there, there's no mentioning of any critical conditions. But if you look at the act sheets, they actually have an indication what is time-critical and what's not. The advisory committee years ago determined that time-critical conditions should be reported by the 5th day of life, which is something that the newborn screening programs really took to heart and have done excellent work to get these screening results out for these patients by those days. These are, this came together because some of the conditions, such as propionic acidemia or MCAT deficiency, actually these patients can die on the 6th day of life or on the 4th day of life, which happens. And so it was really important to make sure that the states do their best to get these results back to the providers so that the babies can be saved. Now, Krabbe disease was thrown into this bucket of time critical because of the need to get the transplant done so quickly. But these patients will not die on the 10th day or the 30th day because, again, it's a progressive disease, but it doesn't kill you just because you have another trigger, such as an infection or whatever. So this is why there is also discussion now, well, should we have another category, maybe calling it time sensitive for Krabbe disease? And the reason this question is here, because some states, again, they don't want to wait for a cyclozine, especially if they can't do it in-house. So when they have a low GALC activity, they're going to tell the physician it's low and you have to consider Krabbe disease, and tomorrow, the day after, we send you the cyclozine result. And so what the question then is, what are the states willing to do? Are they changing this? Are they waiting for the cyclozine, which obviously would be my recommendation? Any thoughts about this, especially for states that may have done the 5th day and really adhere to it versus waiting? Anyone?
So one of the things that we did kind of after this meeting, talking, I'm from Indiana, we've been screening for Krabbe since July of 2020 and had never found an infantile. So one of the takeaways from the meeting here was, some states said they practiced it. And so we always looked at things that we could do from a lab perspective to help facilitate a result. But we did, after this meeting, get all of the parties together, determining each of our role, how to facilitate it as quickly and efficiently as possible, and when we needed to communicate each step. So from the lab perspective, obviously we're tracking when a sample is collected, when it's received, trying to look at pre-testing variables. But what we did do is that we've always done second-tier testing. We went from a simultaneous cyclozine and 30 kb deletion to strictly cyclozine testing. But any baby, we do a daily median cutoff. And one of the things that we did do is that any baby that is less than 8%, we will simultaneously retest and send for cyclozine testing. So we had our first infantile case a couple weeks ago, and the baby was collected at day 1, received on day 3, measured on day 4 of life, less than or 8%. We sent the sample to Mayo. So on day 5, or day 5, Mayo called out a preliminary result while we were confirming our GAL-C. So essentially the cyclozine value in the baby, the cyclozine was 49. So sending that, we sent it on a Thursday. So sending it as we were retesting, I think was the right call for us, and something that we implemented probably a couple years into it. We were repeating everything. And now we have a fail-safe cutoff that we will do simultaneous repeats and cyclozine testing.
Infantile is defined as greater than 10 nanomolar virus. Is that what we're?
Yeah.
Yeah. Okay.
So, in our lab, for not most, all the enzymes, when they are deficient for a sample, we tend to repeat them, confirming the enzyme activity. In case of GAL-C, when a sample comes up deficient, we, along with the confirmation, we start working on the cyclozine value. So we get the second time enzyme value and the cyclozine at the same time. So that saves time.
Okay.
So we're in North Carolina. We haven't started screening yet, but we are working on our verification and expect to go live within the year. But our plan is actually not to retest the decreased enzyme activity and just go as long as it meets QC acceptance and single well acceptance and the peaks look good and everything. we are sending out our cycosine, so we'll just go ahead and send it and use that as the confirmatory, and rather than retest with the long incubation time overnight. So that's what we've done with other enzyme-based tests, and it's worked pretty well. And we do not plan on communicating with follow-up until the cycosine is back.
So currently, when we tested, we did do the low enzyme, and we would wait before we actually reported the actual cycosine. Or rather, we would retest and then we would send out for cycosine testing. But January of this year, after the GAC met and discussed with Dietrich and Dr. Kurtzberg, we decided to change that. We are now on the initial test for GALC. We will send out for the cycosine testing on the initial test, and then we still repeat and finalize that. But the cycosine testing goes out for sequencing, and anything that is greater than, we also worked with Revity to change our cutoff for the cycosine, because it was at 1.25 and we changed it to 2.0. And anything greater than that now is reflexed over to sequencing. We are still discussing whether we look at how fast we can get that test to Revity. We are right now in discussions if we want to continue with the same process that we have right now, as sending it the same day overnight, or waiting until we actually get the second test to do it. But right now we're seeing, I think they like having that test go directly on the same day overnight.
Well, Wisconsin actually in the similar situation like North Carolina. We're not a current screening, but the condition has moving in the process in terms of rulemaking. So my estimate time is next spring, as Dr. Matern mentioned earlier. So I think I hear the colleagues make comments. So as of now, when we say second tier, so it's truly second tier means you based on your second tier test result give you the conclusion. So in that words is we will based on the cycosine to report. So one thing I haven't heard, this is what in our mind is giving this condition is critical, right? Because, so one thing we want to improve is really is the GALC enzyme assay. We're going to try to change it to 3 hours incubation instead of 18 hours. Giving this change, one is accommodated this critical condition, you want a quick result. Second is because you have a second tier and your tolerate false positive rate is much higher. But my understanding recently, somebody, CDC, developed an assay, can make a 3 incubation more stable, more reproducible. So that's the current thing we got time. So in the fall, that's our emphasis. Multiplex assay, we're not going to 18, but we're going to go 10x. So trying to get XLD and the MPS2, everything together. So that's our current plan.
So Mayo is doing our testing, and so they automatically reflects the cycosine if they get a low Z. And so we get the report back from them with both results on it. So that's the first time we would report it out. So, and they're usually really, really quick. So.
I had mentioned earlier that we have similar, I think, to what Missouri said, if activity is very low, then we're sending for cycosine on the first analysis. If it's kind of in the medium range, and I don't know, I send it on the first analysis, but a lot of them are in a range where I'm pretty certain it's false positive, and I can look at the other enzymes and tell. Those we sort of hold on because they just generally, they've always been above. Cyclocine's always been below 2 on these. But I can give specifics if anybody wants on what kind of activity ranges I'm talking about for GAL-C based on a 6-plex neo-LSD kit.
Thank
As we're
you.
going through, Dieter, it's me over here. I just wanted to remind that we have some online panelists as well who can also unmute and introduce themselves or contribute to the discussion too.
Okay, who's facilitating that?
You.
I don't.
You don't need to unmute them. I think
Okay,
they
well,
can
who's,
unmute themselves.
whoever is online and wants to have ask a question, please feel free.
This is Sondra from Minnesota. Can you guys hear me?
Oh, Sondra, yes, go ahead.
Okay. All right. Hi, everyone. We can't see the room, so it's a little bit hard. I'm trying not to like jump in and speak over somebody, but in Minnesota, we do not repeat our enzyme assay. We just send it, we have one that flags, we just send it right away down to Mayo for cyclocine as soon as possible. We're fortunate that Mayo is in our back door neighbor, and so we have a courier that picks up from our lab Monday through Saturday, but we also can arrange a stat courier on weekends and holidays if we needed to. So we're very fortunate with that. And then we'll report it out once we have the cyclocine from Mayo. We did have one infantile case. Unfortunately, it flagged on a Friday, and then so we're sending it down on a Saturday. And of course, it was a holiday weekend, but we called it out, reported out day of life 6, and baby was transplanted on day of life 25. So consider that a success.
Thank you, Sondra.
This is Khaja from the state of Illinois. We are doing Krabbe testing from 2017, and the way we are doing it, once GAL-C activity is below our cutoff, we send it out immediately after repeating the testing. And if cyclocine is above 10, we immediately report the results and follow-up is initiated. Whereas if cyclocine is less than 10, we wait for the sequencing. In our experience, we found that depending upon the sample quality, sometimes GAL-C at 11% of the median can be a infantile case, because we did have those. So depending upon the situation, it's very important that we send these samples immediately. In most of the cases, we were able to report infantile cases within 7 to 10 days.
Thank you, Khaja. Anyone on this side who wants to chime in?
I'll just mention one thing that we do that's slightly different. There's a lot of, I think, similarities and overlaps, but I know what our lab does is we don't use a hard cutoff. We run all the LSD results through the CLEAR tool that looks at all the LSDs, and that has done a good job and that's how we determine abnormalities. We don't use a hard cutoff. We use CLEAR results, and that has done a good job of eliminating sample quality issues. And then I would also kind of add on in terms of how that gets reported. And I apologize right now, I am not a lab person, I'm the follow-up person. So I have to bring it in, but we have a different strategy for handling those results that are 2 to 10 versus the 10 and over. So Mayo does our cyclocine testing, and the folks over at Mayo have been phenomenal at working with us. We have a protocol where they contact our geneticist on call if it's over 10, so that we can immediately, we don't have to wait for the lab to get that and pass that to us. We immediately start contacting families to the point that Trisha Hall has texted me on Saturday night. And I've had emails from Dita where I'm like, he's punking me, no way, but there it is. So that relationship has made it really helpful to be able to act yesterday on our 10 and over kids.
Thank you. So let's move on to the next question. I'm very happy to note that people take away information and digest it and then make changes that are better for the babies that we serve. And maybe later tell me where you do the repeat enzyme activity, does it come back differently? I assume you do this because you're concerned that there may have been a mix-up and the wrong baby is being psychosened. Just wonder. So the next question is goes back to the issue of what we want to screen for, and I think this is where I want to hear from the RUSP-aligned states. What does it mean for you that on the RUSP we now have screening for infantile Krabbe disease with low GALC activity and a psychosine of greater or equal to 10? Does it mean for states that are already screening that you make changes? If you're starting to screen, will you go by this recommendation, or do you feel that it might be too limited? What are your thoughts or actions? Should I pick on one? May, you seem eager.
Just
Go for it.
Nobody. So in our state, we set up is infantile. So 10, psychosine 10 is our set off. But actually listen to Dr. Matern's earlier presentation, the way you report actually do our favor because I wasn't very comfortable with what it is, but because the way you are going to report it and this information will pass on to the clinic, so they have to take care of that. So I think in the way officially do this, and I think actually I want to see some plus side is because we all in a position, if you, for example, for Pompeii, we defined as infantile. So allowed us to set a threshold a little bit different, then you don't have a legal obligation if you miss some late onset. So that's a decision was made consciously. We feel like a balance, pros and cons, that's for Pompeii. But Krabbe, we haven't have experience, but I think it's a little bit different. To me, in the newborn screening, identify the late onset is not a problem. I think problem is uncertainty. So eventually they will have symptoms a lot. Do they need a clinical attention? So I think that's the kind of key thing. So I think I still trying to learn from the people have experience now. If the psychosine between 2 to 9, even that later, they for sure will have some problem, medical problem, or majority will have problem. That way, I feel it's for the program, I would in line to identify them.
You're gonna report out and let them deal with it, or not report out?
We have to, by the cap, we have the reason is that if a Mayo Clinic reported way, just like Dr. Matern indicated, in a report, they will say between 2 to 9, and likely will have late onset. But
You are reporting it out.
We will, because
Okay.
just like everything else, you screening for severe combined immune deficiency. If you have a T cell receptor low, you think about a potentially 22q11 deletion, you still want people pay attention.
And you're reporting out to who?
The clinics.
The genetic?
Because in our report, we'll state that.
Okay, so
Yeah.
you will catch. The
Yeah,
late
we
onset.
will.
Okay.
Yeah, it's why I want to say that it seems maybe it's not too bad because you legally, you obligate infantile, but at some times you may also get other almost go back to the secondary funding, the concept.
I think Tracey Bishop from California online raised her hand, and then we can go to Margie.
Yeah, hi folks, this is Tracey from California, and we're not screening yet. We're going to start next year. But as a RESPA-aligned state, our plan is to have an urgent cutoff of, in the area of 10, right? They're finishing their validations, but to send everything from 2 to 10 for sequencing. So, we will pick up things that are caught in there. We won't call them out as urgent, but we will pick them up. So that is our plan to be broader than just the infantile.
So thank you for that. That's very interesting because you're one of the states that has a RUSP alignment law. So that gives you some latitude as to how you interpret the RUSP?
I believe so. Yeah. I don't think our.
Okay, we won't question.
Yeah, this is a decision Dr. Sharma has made. Yeah. So we're able to, yes. Yes. And we're, planning on doing psychosine in-house. We're so big that, they're also validating psychosine in-house.
I'm done. We're moving on to Ohio.
So Ohio has legislation that says the advisory committee has to consider a condition within a certain period of time of being added to the RUSP, but we don't have to adopt it. We did have Krabbe, since 2017, 2018, somewhere in there, but first tier only without psychosine. But now we are adding psychosine. We're in discussion to get a contract, hopefully within the next couple of months with the lab, and our cutoff will be whatever the low end cutoff is going to be for the lab we contract with, whether that's 1.5 or 2. So that's the update from Ohio.
Thank you. Anyone on that side?
Neither are we.
No? There you go. Sorry.
That's okay. So I guess similar to Ohio, we've been screening since 2019 and we've been reporting out exclusively based on low enzyme. We are not doing psychosine testing, but we are actively working towards adding psychosine testing. We're trying to set up with a external lab to contract for psychosine testing.
I can also add that the advisory committee in Ohio recommended removing the line about opting out. So right now we have basically parents have a line item veto to selectively exclude Krabbe from the newborn screen, just because of how the legislation was written. But the advisory committee recommended that we remove that exclusion opportunity, and that's still in discussion at the state level.
Okay, thank you. Do we have Oregon on the line? Do you want to say something? Maybe? No? Andrea, do you know anything about Oregon? No. Okay. I guess we can move on then. Yeah, what about states that screen baby twice? So there are some states in the mountain regions in particular that screen babies at the second day of life and report out the results. And then they screen them again about 2 weeks later. And so I'm curious to know what they're going to do about Krabbe disease in that term. Do you do psychosine on the first one or the second one? What would you do? And I think we have just one rep. Okay, Mike.
How about Washington, which is, so for Pompe, if they think it's infantile, they don't wait for the second test. I assume if it would be the same for Krabbe if they were to add it. So Pompe, it's a 2-state test and they don't wait for infantile. Means they do enzyme, and if the genotype comes back infantile in a couple of weeks, they don't wait for a second. They probably do it again, but they don't wait to report it out.
Okay.
I assume same for Krabbe.
Probably. While we wait for Utah to get the microphone, what about Texas? Is someone from Texas on the line? No. Okay. Well, now you have the mic.
So yeah, I like what you presented on your slide. So Utah, is planning to screen for Krabbe disease in 2026, which will be linked to or tied to fiscal year 27, as you know, with state, and we have to to present, our kit fee increase. So it's a fee schedule, and in Utah, it's the meeting is held in October. So we will probably provide this information to the basically executive director office in October. Yes, Utah is a 2-screen state, but we don't screen all the, we screen for 44 disorder. We don't screen all the 44 disorder on the second card. Specific to Krabbe disease, and based, when you listen to the talk of Dr. Dieter Matern, it's clear that we will not wait to have the result of the second card. So I think our follow-up will take immediate action after the screen is positive on the first card.
Okay, thank you. Question? Oh, you can't ask without a mic.
They're telling me not to ask this, and so I'm probably going to get kicked out, but that's okay. I'm just wondering, hearing all of you say that you're testing for the lower level, I'm wondering where the consent and everything comes into that. I worry that where the recommendation is to check for these infantile forms, and with more and more of these diseases now, we're getting, I know in ALD, tons of these VUSs, and I really worry that there's going to be a backlash to newborn screening from families when we have more and more that are being diagnosed with something and then find out they probably don't have that disease. And so while I understand sitting in this room, it seems like we want to pick up every single kid that might have it. I do worry that there is a long-term risk to detecting babies that may very well not end up having disease.
I think I agree almost completely, except that if you rely on cyclozine, I think that chance is very low. And I think the backlash will be if you go with 10, that in a few years, those families that have a baby with late infantile Krabbe disease and learn that they could have been picked up by newborn screening but weren't and are now dying, that they might be angry with whoever and might take some whatever legal action, whatever they can. Right. Yeah. So.
But I mean, like, in any neurogenetic.
Yeah.
In any neurogenetic clinic, you have more and more of these cases where we're not 100% sure. Like I know we have Pompe babies. We've even had some SMA that you think are clear. And so I just think that it's important to recognize that when you start testing everyone, I think people thought that ALD having, if you have an ABCD1 mutation and you have very long chain fatty acid elevation, that was thought to be pretty tight too, until you do many, many more testing.
Okay. Kansas?
Yeah.
No one can hear you. Kansas?
Yeah, this is Zach from Kansas. I'm kind of in a unique perspective here. So my brother also had Krabbe before I ever took over newborn screening from Kansas. And so I think I kind of like to speak a little bit to the portion of, the consent portion or what you're worried about when it comes to long-term follow-up. I think the other argument here that people kind of forget is the point of newborn screening is to provide information to the family and information to make informed decisions on a condition, not to diagnose. It's not a diagnosis, it's a screen. And so we're not saying your child has this. Of course, additional screening will need to happen. But if you don't provide that information to a family, what you're effectively doing is also removing their opportunity for things that happen along the lines. And so when we have late onset diagnosis, the thing that you just took away from them is a potential of gene therapy or the other things that are happening very, very quickly right now. And so by not providing the potential diagnosis or not providing that screen of information, you are removing that possibility from them, and you just took their consent away for that. So
I agree for the most part. I think that it is very important for every screening program to be very transparent about what you're trying to achieve. Because with a cutoff of 2 for cyclozine, we will not identify all or maybe any adult onset Krabbe disease cases. And for the reasons I gave earlier, I think that's okay. But again, most important is that you are really transparent about it. Because yeah, if a family that has a baby with late infantile Krabbe disease is being missed might get angry, but if they have to then go and look at the website and it says we're not screening for this condition, they probably don't have much. They're not going to be happy. I don't think it's right, but at least you have been clear about what is included. Joel?
Absolutely.
Yeah, just, I think the point about detecting too many does seem to be a little like what we're seeing so far. We're not picking up a lot in the kind of the low 2 to 4 range. There was definitely correlation from what I saw between levels of cyclosine in the 2 to 10 range that would be more indicative of an later infantile kind of form of disease versus one of these where you really don't know what to tell the family. But I think what we need to do with this group is, as we have been collecting cyclosine data, we'll look more closely at that group and what is the impact? How many are we actually picking up now that everybody's doing it kind of more the same way, and then reassess in 5 years or something like that.
So I just wanted to say, I think one of the things that changed my view on this a little bit, because I remember when this first came up, I was like, of course I would want to know, right? But seeing more families where it has other decisions that now are getting made, like, are you going to have another child? Are you going to do prenatal testing? And then if that child is positive, what are you going to do? So I think that when you're finding out, of course, if it's, again, from my seat, normally I would say, of course I want to know, but we do see more and more families now that are in these positions of, do I do IVF? Do I not have children? Do I do an amnio? And so it has, I just think we should all be aware that it has these further reaching implications.
My experience been Pompeii and ALD is definitely worse than Krabbe in that regard for the impact of that.
So maybe a question, yeah. North Carolina.
Yes, North Carolina. So I just wanted to kind of add my own perspective to it too. I had a prenatal screen that was a false positive, and they told me that my baby wouldn't survive. And now he's 6 and he's perfect and everything's fine. But kind of still, even though we went through all of that, and I still worry about him because we chose not to do the extensive, more esoteric gene sequencing. I still would rather have had that result. But being in this position, I'm really, really passionate about reducing those false positives. So I think that that is our obligation, is not to, this is my own personal view, so don't hold this against Scott in North Carolina. But I think it's not to not pick up these babies, but to reduce the number of false positives we have, like Joe said, sharing our data amongst each other. And one thing that I've really been working on lately with Pompeii and in collaboration with Duke, which also we're really spoiled because we have Dr. Kurtzberg leading our follow-up. So we feel confident she'll be able to, manage those patients that are more ambiguous. But I've been looking at different ratios of enzymes. And so I looked at GAA over IDUA and could eliminate 100% of our false positives for Pompeii. So we're working on a publication, but I'm happy to share that information. But now that we're doing our verification, we're looking at similar things for that too, for Krabbe. So that's kind of really my own personal perspective on it.
Okay, thank you for that. Another
Hi, I'm throwing out another research idea in addition to collecting data on levels and gene variants is surveying other stakeholders, so patients and families who have gone through newborn screening and what their perspectives would be on getting one of these intermediate results or finding out or not finding out. I don't know if that's been done for Krabbe or for other similar conditions like Pompe, but that could give us another perspective on this.
Yeah, there are
Volunteering to do the study, but
yeah, there are a few studies, papers out there that address it. Actually, just last week there was a paper by the metabolic specialists that take care of adult patients and who were discussing the benefit or not of screening for a condition with late onset disease, and they were.
And what did they find there? What were
based on the abstract? They were not very happy.
Okay.
So
That's good to know.
they didn't think it was a great idea. So there's all kinds of data out there already. Now. Moving on, I think these discussions are very good. And I think, again, about the transparency and what do you want to do. I think most of your states have advisory committees with stakeholders. Is there an opportunity who's working on the agendas that these can be discussed as to what you actually are screening for? I think, again, if you go to any newborn screening website, it is always the boilerplate. This is the list of conditions we're screening for. There's no differentiation between the various forms of the disease. And maybe that should be addressed and be more explicit. And I think that if it's done with the stakeholders in the state, you should have also input from the patient advocates as to what this all means and have an open discussion. Mike.
As we're starting that discussion, just a 10-minute warning. We have about 10 minutes left in the panel.
So surveys of families that are about to have a kid, what they want, I think is essentially useless. For example, I think most of us don't know whether we want late onset or not. How could we know? So some of the things that Beth Tarini is doing, I think are pretty good to follow these families that are confronted with a possible late onset disease over 10 years. I think only then will we know. But I mean, explaining to parents at the beginning when they're about to have a kid, I just don't think they would know how to decide. I really think they cannot decide. I think most of us in this room cannot decide. And I think it's essentially useless. So following them 10 years out is the only thing that makes sense to me.
I think that will give you the information, but I think you still, on a state level, should be very clear about what you're doing. And again, if you have the stakeholders, at least they can talk about it without being impacted themselves, but they can go back at their own experiences with other screening tests that we all go through and are either happy or unhappy or disappointed about. I think it might be a start. But yes, long-term follow-up is important and is part of newborn screening and needs to be done. And maybe, Angela, do you want to tell us anything about the different perspective just for infantile Krabbe disease families that you experienced maybe in your state?
This is what happens when somebody knows your cases. So we have had 3 positive newborn screens in Georgia for Krabbe. They were all real infantile onset kiddos. When I was here last year, we had the first one. That family, let me just preface, all 3 families were pulled into follow-up very quickly and offered testing and care right away in a very timely, appropriate fashion. The first family opted not to pursue transplant or really any care, and Stephanie can probably speak better to that, but they declined basically everything. And then a year goes by and we had two more infantile kiddos who both went in and got transplants. One of those children unfortunately died, but the other kiddos, so far, so good. The first family, it was, I think, a little heart-wrenching for everybody involved that they chose not to pursue care. And they have since spoken through the grapevine that they actually regret that decision. Having had time to learn more about what that means and what's available to them and that sort of thing, they I think they would have done things differently. You know, hindsight's 2020, right? Like, you know, shoulda, woulda, coulda kind of thing. I hate to not, I'm not trying to blow it off, but at the same time, they very much, I think, acted in the best way they could have at that moment in time. And now they're not so panicked and had more time to learn more information. You know, what are you going to do with that? Other than, you know, wish that our OBGYNs could somehow convey more information to our families about diseases and newborn screening and connect them with information. I will say that part of, and we talked about this last year, part of what, there were many things that influenced that family's decision. And one of them was the high rate of false positives that they had heard about from a family member in New York prior to them doing cytosine testing. And that gave them very much the impression that this will be nothing. This is probably a false positive.
What about the third case?
I'm sorry?
What about the third case? Was there any change in heart as to the decision they made initially?
Our third case.
The one got transplanted and passed away.
Thank you. Our third case is the one who transplanted and died. I don't think they regret that one bit. I think they are sad, as anybody would be, to lose a child. But I think they have also are comforted in knowing that they did everything they could.
Okay, thank you. Anyone online have any comments? Okay. Now, do you have any requests for Hunter's Hope as to what they should be doing to help in your state with anything?
You know, laboratories with this rare disease and come to the point is you do need the true cases to validate what you've done. So I think I need one like early next year, at least one, because as a cap, you need to minimum 20 specimen. So when you set the validation, everything, then you set the threshold, then you go on to do the screening positive. So let me finish, please. So the 20 is not have to be patients because of the mix. And, you know, at least you have a 2 or 3. I think community getting together help. That's can be useful.
I'm not sure exactly where that getting 20, I mean, what's this requirement? Where are you getting that from? Because we certainly don't have that as a requirement. I would not be running Screen Plus at all.
CAP checklist. It's a part of clinical validity, like you said, threshold. If you want, I can give you check copy the number. Well, I think our lab follow the CAP guideline to assess but you, for the rare disease, you also can use a publication. I think early on,
Yes.
actually, I wrote a notes, the multiple medium being published said this valid method can be helpful too.
You have to use newborn blood spots, and you're not going to get 20 newborns. You cannot use older patient blood spots; they're irrelevant. So, this is the first time I'm hearing this CAP thing for rare diseases. I think it's
Yeah, I
know this is
but I think it's impossible to get 20 newborn Krabbe.
I think the 20 is a minimum number, but the 20 is not all have to be disease.
Right, the 20 is a reference.
So just.
So there is a reference range and the minimum is 20, if not 120.
Yeah, okay.
And then there is a disease range, which you really want to have, but you often cannot get until you actually start testing. But yes, we certainly wish we had all the information when we went live with an assay, but for these rare diseases, new biomarkers, we would never get done and have an available test. Okay. Yeah, and I would recommend more than 20. Okay, we have 1.5 more minutes. We can talk about something else that you're interested in, or we can have Rob take over, or take us to lunch, or whatever is next. Any final words? Yes.
Sorry, I have a really quick question. So I didn't know, maybe this is a question for Hunter's Hope or for other states sitting here, but how are you addressing specialist centers in your states? I know for some states, specifically Kansas, in order to add a condition, we feel that it's important that we can take care of that child in our state, whether that be transplant or care or anything. And as we get more and more specialties, specifics, especially like lysosomal storage disorders, where those specialty centers are not in our state, when we refer individuals outside of the state, we start to look at like barriers of transportation, all those other things. And so how are you guys addressing that? Or are you addressing that? Or are you speaking to your geneticists or care centers about maybe you guys aren't the best option on this one? How is that going?
So I don't know if anyone here has something to say to that. I think, again, it goes back to the issue that you really want to involve all your stakeholders. And if you have a specific disease like Krabbe disease, you want to talk to the transplant people in the state first and then reach out to others. Maybe Dr. Orchard will address this later, because he is often asked, and Joanne as well, by other states, what can we do and how do we get them in and who's going to pay? Because Kansas, Medi, whatever, may not pay as much or cover as much as another one. So these are very important issues that need to be addressed, preferably before you get your first one, which again will be on a weekend. So be ready. Everyone in the state has to be ready for newborn screening. Babies are born every day. They don't care about weekends. The OBs sometimes do, so they deliver actually so that they don't have to worry about the weekend, which means you get them on the weekend. So thank you, everyone.
Thank you. All right, excellent, great discussion.